Our next guest would know this very well. He's a doctor. He's a medical doctor. He's the chairman of the National Cancer Institute, Dr. Timothy Olwenyi. And in a previous life, he was the leader of the Private Hospitals Association of Kenya. Daktari, good morning.
Morning, Eric.
How are you doing?
I'm well.
Good to see you.
Yes.
Karibu sana.
It's a pleasure to be here as usual.
Karibu sana.
Yes.
I'm sure you feel good when you hear, private healthcare expanding like this, or just access to healthcare being made more possible. Right?
Yes.
And when you talk about now specialty care, which is what we'll be talking about today, we'll be talking about World Hospice and Palliative Care Day. You'll tell us more about that. It's a conversation that many people don't even understand. The National Cancer Institute is an institution that's very, very important that many people don't understand and don't know about. You'll tell us about that. Siti will welcome you with the day's proverb. Siti, what is that proverb?
This is a proverb from the Kingdom of Morocco. We are traveling and visiting countries of the Maghreb, and we started with Morocco. Next week we'll go to Algeria, and we will look at proverbs and we'll look at the country and talk about it. This is a monarchy. They have a king, an all-powerful king, not these ceremonial kings whom you see on public holidays. This one actually determines what happens in the country. I like reading this. He's commander of the faithful. He's commander of the Moroccan Armed Forces. He is the head of the Supreme Council of the Judiciary. He chooses a prime minister from the political party that wins the elections. He removes ministries and creates them. He terminates parliament, meaning this fellow has power. And what's this fellow? He's called King Mohammed VI, which means there was a fifth and a fourth and a first. Anyway, he's the sixth. The proverb. They begin as neighbors and end up as mice.
That one, but they begin as neighbors and end up as mice.
Oh, neighbors, not friends.
Daktari, what's your interpretation here?
Eric, you send this gentleman back on leave. I don't know why he digs up these proverbs. They begin as neighbors and end up as mice. Well, I'll assume my interpretation would be that we've got a relationship which is kind of symbiotic as neighbors. And if they end up as mice, I'm assuming mice are vermin, so some sort of parasitic relationship. So something that morphs from a symbiotic to a parasitic relationship. That would be my interpretation.
Yeah. Sasa weka science chini. Tell us, bana, in normal language.
Oh, in normal language.
After they've been symbiotic.
And parasitic.
Parasitic. Okay. The parasites have been symbiotic. We've got that one now.
And they are vermin.
So it's a relationship that's mutually beneficial at the beginning, but tends to be more one-sided, where one person is taking advantage of the other. That's what I'd interpret it as.
The beauty of a proverb is always this, the diversity of interpretations. And it opens your eyes to how people will look and then see. But I love your interpretation of it. It's wonderful.
Yep.
In a very brief sentence, you've actually summarized it quite well. Thank you.
And it basically just speaks to the issue.
Yeah.
Yes.
Goes straight into it. It's like, just a doctor operating, and I'm a kata, I mean, this mambo mingi. Mambo mingi, you forget it. We need to get to the cancer.
Yeah.
He's the chairman of the National Cancer Institute. What is that institute?
The National Cancer Institute is an organization that was set up in 2012 under the Cancer Prevention and Control Act. It is mainly charged with matters to do with treatment, prevention, and control of cancer in Kenya. And it provides more leadership, oversight, and coordination of activities in this cancer space. So that is the main mandate of the National Cancer Institute. Of course, it does that under the Ministry of Health, so it's not... It's done with definitely the oversight of the Ministry of Health, which is the parent ministry, because that's the one that again sets the overall legislation that runs everything cancer in this country. But that's it. That in essence is what the National Cancer Institute is about. So it works together with many other organizations. Any organizations that are involved, for example, like in today's topic, you've got hospices and palliative care organizations. It is in charge of promoting awareness to do with cancer in terms of ways in which we can prevent cancer. We coordinate the treatment, make sure that the quality of treatment that cancer patients are getting in this country is up to standard. We make sure that cancer patients, for example, are not discriminated against in terms of their rights and civil liberties. That's a major concern. We see the quality of treatment that they get, and anything to do with the welfare of cancer patients in general falls within our mandate. So in general, that is it. And then also aspects to do with education, to do with research, also promoting that. And more importantly, also one of the most important things is that the cancer registry, so that we've got data that is local, that is relevant, that helps decision making in terms of cancer, whether it's in terms of prevention, control, or treatment. So those are that in general is the mandate of the National Cancer Institute.
Cancer registry. You know, this is a conversation that has been there for a while. Like, do we actually have the statistics of cancer patients and the types of cancers in Kenya? Have we been able to get this now as an institute?
Well, it is work in progress, and one of the challenges that I think there is in this country is that we have got to be able, for you to be able to get that cancer registry, number one, we have got to have proper diagnosis. That diagnosis has to be made, and then the information also has to be relayed with the specific facilities where people are going. So you find, for example, there's some people, for example, who have cancer which are not even diagnosed.
Yeah.
So those are going to fall through the cracks. So eventually, this is one of the reasons why it was important for us to have a system where we can be able to have all this data in one huge database and have that transmitted centrally, and it'll help in decision making. So that is work in progress.
Okay. Into the conversation for today, which is hospice and palliative care. What's that?
Well, palliative care is an area where we have it's an interdisciplinary care approach. In general, it is for patients who have got serious illnesses, chronic illnesses, and those in general that are life limiting or life-threatening. So it's an interdisciplinary approach so that we are able to provide, first of all, the emphasis is usually in hospice and palliative care, is to optimize the quality of life. You know, quality of life, optimize quality of life, and let me just add, secondly, also, other than optimizing the quality of life, is to reduce health-related suffering. So those are two major facets of hospice and palliative care. The reason I talk about chronic illness, when you've got a malaria for 2-3 days, usually the psychological impacts are minimal. You get treated and you get well. When you've got any illness that is chronic, and especially one that is life-threatening, then now you go into a realm where we're talking about more psychological effects, and we're talking about something affecting not just you, it affects your family, it affects your ability to earn, it affects your well-being.
Yeah.
So you can see in that space, it is more multidisciplinary because now we're involving all manner of caregivers, and that's the difference between hospice and between palliative care and the other realms. Now, palliative care and hospice care, slight differences, but palliative care in general, they will say, is something that you can be given concurrently with curative treatment. For example, you are on cancer treatment, but there are certain symptoms and so on that still need to be relieved. You can get palliation at the same time. Hospice care in general in the past was now when they're saying, I don't like this term, but people used to say a terminal illness, when you've got a terminal illness. I don't like that term, terminal illness, because first, I think all of us are terminal. All right, so the fact is all of us are going to die. We just don't know when and how. It's just that with people, when you've got certain illnesses, you see the end as sooner rather than later. However, it also, in terms of caregiving, it became a problem, because when you've got somebody and you labeled as having terminal illness, the impression is there's no more that can be done. And then people were taken to hospices, more like to be dumped there, in terms of there's nothing more we can do for you. Unfortunately, most of the time, again, it was an issue of when the resources become depleted in the regular healthcare system, then people say, now we can move you to this.
hospice.
All right? Whereas the truth is, there's still a lot can be done even when illnesses cannot be cured. And again, there's a lot of ethical issues around this, because you must remember that also as in medical ethics, there's this aspect about people are very clear about beneficence. We are supposed to do good, but we're also supposed to do no harm. And there are times when actually doctors don't know also when to stop. And there are times when it is right just to stop with the curative care, because we cannot make the endurance of the cure for the illness more painful than endurance of the same. So there are times when, and we mean well, but there are times when actually we need to stop. And especially even when you've got people who've got illnesses, sometimes you've got people in this country who are on, for example, some chemotherapy, and you sometimes look and you wonder, where is this going? Because quite clearly, it is so far gone. And sometimes you deprive the people of the opportunity to be able to spend their last days in terms of doing things that are more useful, in terms of spending time with family, being at home, you're exposing them to side effects. So that's another ethical issue which I think needs to be addressed, because we need to make sure that the people who get therapy are actually people who are going to clinically benefit from it.
So you didn't define the difference between hospice and palliative care.
Well,
Hospice is institutionalized though.
Actually, both of them can be even hospice care. Hospice care is actually more. Hospice care can be institutional in terms of inpatient care or home-based care, and palliative care. The only difference is the timing of when you do it. But in general, the words, there's a lot of overlap. But a hospice, in terms, hospice is actually more of an institution. And in Kenya, we've got only outpatient hospices. But now we have palliative care units, remember, that are mainly in facilities, especially the public hospitals. So we've got a lot of overlap in terms of that. But for me, if you were to ask me, especially at the end of life, if we can have a system where we have people taken care of within their homes, it would be better. But that's one of the things that we want. It's got a lot of things to do with how we devolve that care, how we provide healthcare financing, so that we make sure people are able to be comfortable at home as opposed to being in hospitals. One of the things that I was very vocal about in my previous life as the chair of SHA is that I was very keen that we should get palliative care and home-based care and pay for it so that people can be able to stay at home. Because if you provide care only within hospitals, what you incentivize happens. Everybody's going to move from home and come to the hospital because that's where the care is being paid for.
Yep.
So what we need to do is facilitate the ability for patients to be taken care of and be comfortable within their homes.
Yeah. Because I think you touched on what I was going to, bring on board, because that's the conversation. There's one thing to create these institutions, access it. There's another thing to afford it. And I'm glad you touched on it, because the conversation now, and you saw what happened, I think, at the beginning of this week, I suppose, if not last week, the kind of pain and agony that a number of patients were going through based on the transition we had. From NHIF to SHIF or SHA, and the aspect of ensuring some of these particular services that you're talking about. I mean, I speak for the layman, for the person in the grassroots, who is really thinking, where is my place in all this palliative care? How far does it go? I know you've mentioned public hospitals, but I know places where it's really deep grassroots. It's a reserve, and sometimes even the hospitals, clinics there don't operate over the weekends. I don't know if you've seen such scenarios.
Yes.
How far are you extending this, discussion of today? How far are we going, and how far have we reached, really?
Healthcare financing is a very core pillar if we're going to be able to succeed in providing the care that people need. Healthcare financing is crucial, because cancer is one of those illnesses, being a chronic illness. We have seen it time and again. Yeah. You start with somebody who is unwell. First of all, you've got all those costs, direct and indirect costs related to the care. Yeah. Then first thing that happens, there's imperfect income smoothing. And by that I mean, you're not able to sustain your level of income, because first, most of the time, you're out of a job. If you're somebody who's informally employed, then what happens? You're not going to work, you're not getting paid. If you're a hawker and you usually walk around, if you're in hospital or you're unwell, you're not getting paid. Then the next thing, you come to the saving. Any savings that you have disappear. Then after that, you go to the next level again. Now you start disposing of assets. Then next, you go to the level of now you're borrowing and so on. So that's why healthcare financing here in this space is crucial, because if you're going to be able to access care, leave alone having the facilities might be there.
Yeah.
If you can't afford them, you can't access those services. Yep. And that's why it was extremely important, even as we tried to transform our healthcare system and our healthcare financing system, it was crucial. It is painful to see the kind of things that we saw a short while ago. That should never have happened, if you were to ask me. It's unfortunate, but it is what it is.
The discussion around cancer in this country has increased exponentially. Why is that so?
Sorry, the discussion there?
Around cancer, about cancer.
Yes. Cancer, what happens is, I think in general, if you ask me, cancer, if you look at how cancer develops, first of all, cancer can only develop in cells that are dividing. That's why you don't have cancer of the hair and of the nails. So the more you have cells dividing, the more likelihood you'll have cancer in those cells. That's why you've got certain cells which we call, if it's dead tissue, you can't have cancer there. Those that are slowly dividing, cancer will be rare. For example, you rarely hear about cancer of the heart, for example. or of the lens or of the neurons, leave alone brain, but the brain, the neurons themselves don't divide because there's less likelihood of them to form cancer because they're not dividing. Then those cells that are dividing very fast, like those in the gastrointestinal tract, those things because they keep being sloughing off and being replaced. For example, scales in your skin and so on. Those are the areas where you get a lot of cancer. Breast, for example, in breast tissue, cervix and so on, those are the places where you get a lot of cancer. So in terms of cancer and its development, then you've got now, first of all, people have got predisposition. Some people, it's genetic, it's hereditary. That you can do nothing about, all right? Other than looking actively to prevent, detect early, and to be able to manage. But there are also other factors that are causing the increased incidence of cancer, things to do with our lifestyle. Smoking is a big no-no. Smoking and tobacco use is one thing that I've never had anything good about. I cannot say anything good. It can only do
Doesn't
harm,
keep
isn't
you
it?
warm?
No.
Okay.
Okay. I've never had that one. But in terms of health effects, there's nothing. Smoking is just bad. And it just doesn't increase just the incidence of lung cancer. It predisposes to other forms of cancer as well. But these are now causing tissue damage. And when there's tissue damage, there's a tendency to repair. You're increasing the rate of multiplication. Again, you're predisposing yourself to cancer.
So do we have more incidences of cancer in this country? Or is it that we've become more adept, we are better at diagnosing and understanding it?
I think it's a combination of both. Our lifestyles have definitely contributed to the increased incidence of cancer as we get in touch with more what we call carcinogens because we are ingesting them, we are smoking them. There's an aspect of pollution. There's also obesity in itself, which is also a risk factor for cancer in itself. So there are a lot of things. As we use more drugs and so on, I'm sure the incidents, those things contribute. But then again, the aspect of diagnosis. In the village, I'm sure in the past, there are a lot of people who used to pass away. I know in my village, there's a storm called Yamo, which is like a wind. They just say it's like a wind. Somebody just got this wind and died, I'm sure. A lot of those things were possibly cancer, isn't
Or
it?
witchcraft.
So there are a lot of things that before were not diagnosed that we're diagnosing now.
Yeah.
So it's a combination of both. But the truth is, cancer is going to take center stage in terms of our healthcare system. And the truth is, again, a lot of the cancers are prevented. Eric can't stop laughing. There are a lot of cancers that we have that are preventable as well, because we have to limit these things. It could be even up to be 4 out of 10 cancers. So those are the things that we need to do.
There are parts of this country that have been mentioned as having higher incidences than others. What is the predisposition? What is it that one looks for when you're saying that certain areas not are likely to, but already have that predisposition?
Well, it could be something to do with the environment. For example, it could be something to do with the diet, with their lifestyle. For example, things for example, people who've got diets predominantly smoked food, smoked fish, and so on. Possibly those are things that are high risk in terms of esophageal cancer and so on. So it's got to do with environment. It could be something pollution. There could be some factory. There could be something in the environment that is causing increased risk of cancer. So there are a lot of components that it's a very complex space. But in general, suffice it to say that there are a lot of things that we can do as prevention, and one of the things that the National Cancer Institute that we have to do is to promote awareness in terms of being able to limit, and then prevention, early detection, because especially in a country which is resource constrained like ours, we cannot afford to be waiting and getting people when they're diagnosed late. We have to prevent those that we can. Those that we end up getting cancer, we have to diagnose them early and manage them accordingly.
The prevention story is a good one, Daktari. When it's told, it sounds really nice.
Yes.
But it's not just for cancer. When you talk about healthcare,
Yes.
it is argued correctly, that it ought to be the way. But that's where it begins and ends. We talk about it. How do you go about preventing or limiting the possibility of people actually acquiring cancer? What is it that you do? Early detection, yes, test. But having known the predisposition and the factors that contribute to it, what is it that needs to be done?
Awareness promotion, so that we promote healthy lifestyles. And people will get to know that, number one, these are the risks that we put ourselves to if we engage in certain behaviors like I've talked about, the smoking, excessive alcohol consumption. We talked about some viral infections, for example, which have predisposed people to cancer, for example, HPV, EBV, and so on. We need to be able to look for ways of being able to control that, diagnose it early, and controlling our environment. So if there's an aspect to do with pollution, we have to be able to control it. Let us make sure that foods that we're having in this country, for example, the level of toxins, carcinogens. We've got a lot of pesticides possibly in our environment. So those are the things that we need to be able to manage. But more importantly, when it comes to screening, and this is where I'm saying in terms of deploying the resources, the cancers that are most common, let's first of all start with the ones that are most common and do something substantive about them. It's breast cancer, cervical cancer, prostate cancer, esophageal cancer. Those are things that we should be able to focus on and concentrate and look for ways of being able to diagnose early.
Yeah.
There are some that are more difficult. For example, the gastrointestinal cancers, those ones that are alimentary canal. Usually, most of the time, you have to take a scope and look in. It's a bit more of an invasive procedure. But for colorectal cancer, for example, if we can be able to see blood in the stool, we've got certain tests we can do for prostates. For men, we can be able to do PSAs. For breast cancer screening, we can be able to do that cervical cancer screening. If we're able to start with those, because by and large, those are almost up to 50% of the cancers we deal with in this country. So that would be the area where we want to deploy our resources, where we're getting best bang for our buck.
Dr. Timothy Oluenyi is the chairman of the National Cancer Institute. He's our guest today. Tomorrow, 2nd Tuesday of October, like happens every year, we'll be commemorating World Hospices and Palliative Care Day. Daktari, this is a big conversation, and Kenyans don't actually get the hospice and palliative care. The Kenyans who go and work abroad, for example in America, and they're in the care homes, those are working in palliative care homes, are they not? It's hospice and palliative care.
Well, palliative care is specifically for those with illness.
Those ones who are
You've got certain homes that take care of people who are elderly, for example, who have to stay in certain places.
Yeah.
So that's different. But when you've got anybody who's got serious illness that is chronic and life-threatening, and especially when it gets to those points where cure is no longer possible, then they got to get more and more involved into palliative and hospice care.
Okay.
Yes.
Yeah.
In Kenya, do we have many of those?
Yes, we've got a lot of hospices and palliative care units because, by the way, starting with the Nairobi Hospice, we started in the late 90s. I remember when I was a young doctor, once I graduated, especially things to do with palliative care, we were not taught much about that in med school. So I remember, and here I'm giving away my age, in 1999 I went to the Nairobi Hospice and I said I wanted to learn a little more about cancer, especially in the terminal stages, because you realize when you're out there in the field, curative care, you're very clear on what to do. But once it gets to the point where now cure is no longer possible, then you feel stranded. And then you don't have this multidisciplinary approach where you've got a team of people who can take care of them. And you find that you can't do much. So that's what hospices were created to do. So that's why I talked about the interdisciplinary component, where you've got caregivers, whether it's nutritionists, whether it's medical doctors, it is nurses, it's physiotherapists, it's speech therapists, and so on. Anybody who is going to help in the making these patients comfortable. And that's why I talked about being interdisciplinary. It has got to do with quality of life. And the emphasis here, we're not adding days into people's lives.
Okay.
Life into their days.
It's life into the days.
That is the
Beautiful.
difference. That is the difference. And then in addition to that, anything health-related suffering and especially pain. We've got so many patients in this country who suffer through pain. And I remember even at that time, and even up to this time, you've got people who are terminally ill and in a lot of pain. And somebody tells you, I'm not going to give these measures in terms of giving certain drugs because they're going to get addicted. You know, opioids and so on. I'm like, so what? You understand? The objective has to be to make patients comfortable, and you go to whatever extent you need to make people comfortable. And that's the only way that they can be able to function, add quality into their life. You might have somebody, for example, who has got some last words he wants to be able to tell his family and so on before he passes away. And in the circumstance when they're in a lot of pain, they cannot be able to function. You deny them that opportunity. And that's why I'm saying it has to be one where care shifts. Care shifts, and the focus, in fact, as you go on, the focus even becomes more on the family and the caregivers as opposed to the patients themselves. And that's why I'm saying that mindset about palliative care, it is important. It is not just an issue of saying hospice care, that when we can do nothing, when you run out of money, send you to the hospice, all right? But there are hospices that are functioning in this country, palliative care units. The only problem is we've got almost 800,000 people in this country who need palliative care. The proportion who access it is dismal.
Why?
It's a very small amount because we don't have the resources we've deployed to this function. At the end of the day, and even at the hospices, you realize most of the time the funding was dependent on external donors. All right? And it has to be, and that's why the issue of healthcare financing again comes back, because you have got to make sure that if it is important, then we have to fund it, isn't it? And so that's one of the biggest shortcomings we have in terms of funding, and that's why I've said this funding also has to be continuous from the stage where people are receiving active care to the point where they're in hospital, to the point where they're going to be at home, and all the way up to the point when they pass away.
Interesting. You know, every time Dr. speaks, he mentions something I'm about to ask, as the resource challenge. But I also am very invested in people's mentality. Yeah, maybe they're listening in today and they're thinking, well, that is something for the rich people. You've heard that before. This mentality of ayoni ya watu wako wanaweza. Yeah, but there's also another concern of people are not mentally confident to be in these spaces. Perhaps if you could just demystify some of the myths you have heard or some of the fears the public might have in as far as accessing, palliative care. Is it some think it's a sign of, giving up? Family members could feel it's a sign of giving up on their person. Maybe you could share with us the need to have all these other, people or professionals around your person deeper for them to understand it's not just a matter of we've given up on you. It is a positive, and I know you've mentioned it, but just to change the mindset that lies with first the patient and the family.
I think one of the first things that has to come is, first of all, the healthcare professionals who are involved in curative care have got to be very clear when communicating this transition to hospice and palliative care. It's not one of those where we're saying there's nothing we can do for you.
Because that's what many will.
It has to be clear that we have done what we can in terms of the curative care.
Now
you need to move on to the next stage of care. And this is what we're going to do for you. And kind of also enumerate. But it's not one of those where you're saying, I'm handing you over to so-and-so, and we're done with you.
It's a next stage of care.
In fact, a lot of the time, there's still room for them to be able to come back if there's need to be referred back and forth. But the key thing is just a mindset, first of all, the healthcare professionals and how things are communicated. And also, that's why you've got a lot of people, for example, people who are psychologists and so on, who are involved as part of this team, because the ramifications of a life-threatening diagnosis or life-limiting diagnosis are massive to a lot of people. So that's why I'm saying it has to be handled delicately, and it has to be handled by the professionals who are competent to do it. Now, there's nothing to say, there's no predilection in saying that socioeconomic status is what determines whether people get cancer. In fact, the people who bear the brunt of cancer and its effects is going to be more those people who are low income. And that's why it is important for us to be able to protect them.
You said healthcare professionals who understand. Do they? Can we confidently say that, in the many healthcare professionals that we have, from the doctors, especially now those ones who are dealing with these chronic illnesses, and the nurses and the other professionals, that they understand very well. But I get to this stage, then the most logical thing then is to move to the next step. And the next step is going to be palliative care. And palliative care does not mean that I've washed my hands.
Yes.
Because I'm a cancer doctor. And now this guy, we've tried everything, so let me just hand them over to nurses. Do they understand?
I think by and large they do. There's one thing to have the knowledge. Another thing to have the attitudes and practices change as well. And so that might be the area where we have a challenge. And I know healthcare professionals in this country are generally under a lot of pressure. But what I would appeal is there are certain patients who require a little more time than the regular patient. And this is going to be one of those in that category. So it is very important that even if you don't have the sufficient time to devote it to their care, I think it is important that you involve the professionals who will still give them the care that they need. Because sometimes you've got a long queue of 40, 50 people you have to see in a day. You've got some guys who've got malaria, some guys with some pneumonia, some guys with the flu, and so on. Then there's this one person who comes in who actually happens to have a life-threatening illness. That's why I'm saying it has to be that we look for ways in which we can be able to facilitate these people getting a little more attention than everybody else. Because even in terms of explanation, one thing you must remember, somebody never ever forgets the day and the manner in which their cancer diagnosis was revealed to them. And those are the things that sometimes we might forget as doctors. But the interesting thing is, when you're on the under end of things, if you've got somebody who is a relative, I've had parents, for example, a father who had cancer and so on, when you're on the under end of things, then somehow you kind of see where the problems in our healthcare system are. And it's not even just in Kenya. These problems are there worldwide. Even if you've seen, we have got some certain things that we need to address in terms of how we communicate, how we empathize with people. Because you've got people, for example, I've got a patient who was told by a doctor in one of the hospitals out of this country, just told, there's nothing we can do now. Maximum 6 months.
I think that's common.
Right?
And that's
Yeah.
put like that.
And guess what? This patient was alive 2 years later, right?
Yeah.
So there's certain
And
things.
they always look back at that doctor and say, eat that.
They even make songs. They
I'm
Right?
alive.
create
So
songs
sometimes
around it.
we make fundamental mistakes in terms of communicating certain things. And I remember once we had a patient when I was a student at Kenyatta National Hospital. There's a time when I had, you know how you listen to chatter and you listen to patients talking, and somebody goes in for radiotherapy and they are given an appointment. That time it used to be like 6 months later.
Yeah.
And you know what I had them saying? They said these doctors, what they do is they look at you and assess and see how long you're going to live and give you an appointment date after your
you-
anticipated date of death. You see how that comes out? So the impression is the doctors actually have got no intention of doing anything for you. All right? Of course, that is not true. But you can see what the interpretation from the point of the patient was.
And it tells me
Because
come-
first of all, they don't understand. You're telling me I've got a life-threatening illness.
And then
then
tell
telling
me
me to
come
come 6
February.
months later. But the doctor also doesn't have a choice. They're looking at this queue.
Yeah.
And, that's when the next booking is.
Dr. Is there a unit in medical school where you're taught how to counsel patients?
I'll say there is, but I don't think, and I have to be honest, I'm a little bit of an older person, so I'm going to be talking about my experience at that time.
That's what I'm interested in.
It was not sufficient. And in fact, let me tell you, there are a lot of the things that once you come out of medical school, you realize are the main things that you're going to be dealing with, and you're ill-equipped. So there are certain things that you need, again, retraining, and that's what becomes important. And that's why I was saying, for example, I had to come back and say, let me learn about palliative care. And it was the same, for example, with HIV. The time when I went to school, HIV management was basically, there was not much that could be done. After that, ARVs came in, and I had to go back and say, let me learn about these things, because you realize you're ill-equipped. So the aspect about continuing education, and which now has become even much more prominent, fortunately, because with globalization, the issue of doing webinars and doing things online, now things have improved. Those days, it was not that easy. You'd have to go back to school physically, look for textbooks and so on. So these things are improving, but there's still a lot of room for improvement in terms of how, especially, we manage patients, and more importantly, we get support from other professionals who are better at doing this than us or have got more time.
Dr. Would you say that, what you're driving at is that it's important for medical personnel to also understand that we need to move to the patient-centered approach in as far as this particular care is concerned? Is that what you're saying? Patient-centered, or?
I think care in general always should be patient-centered,
Yeah.
but especially in circumstances where you've got illnesses that are chronic, that are life-threatening or life-limiting.
I know this might not, be the best time to ask it, but it's important because misdiagnosis. I keep talking. Sometimes people are like, "Oh, she speaks," but I speak for the man who's probably boarding a matatu right now, and a woman or a child, for that matter. And people are sometimes, because we need to screen, we need to come out, because there's no way I would know I need to come for treatment if I don't know that I have cancer. Sometimes we come out when it's too late, when now it's a serious migraine, I'm supposing, but misdiagnosis. The cases, if you've heard of any, perhaps if there's statistics around it, but this has gotten the level of confidence a bit low for majority, if I would speak for, to even come out for the free screenings, because they're like, what if it will not be as efficient? What if I will be treating something I don't have? What if mentally I'll be tortured over something I really don't have? What would you speak on? What would you say in regards to this scenarios? Even if there are few, those lives matter.
Misdiagnosis is a bit of a complicated, a mixed bag. We must remember, first of all, you've got patients also have a role to play when it comes to misdiagnosis.
Okay.
Patients first must give the right information. And I'm sure you've seen circumstances where people go in and they're asked, do you have any difficulty passing urine and so on? No. Right? Or have you ever seen blood in stool? No, for example. All right? So first of all, patients have got a role to play in terms of giving the accurate history, and then, of course, also being able to access the facilities. Now, then there's an aspect about the medical facility and the healthcare provider. If those things have got shortcomings, and we know in our country in general, we still have a lot of shortcomings in terms of the availability of qualified personnel and the availability of the facilities for them to be able to do their work properly. So sometimes the misdiagnosis comes because of these shortcomings. Sometimes the information is not right. You don't have the right healthcare professional. You don't have the right equipment to be able to diagnose. So first of all, that causes a lot of delay. So sometimes misdiagnosis and delayed diagnosis are a mixed bag of things. Of course, there are also times when you've got somebody who is not diagnosed properly because they also don't have the resources. Sometimes you're told, go and have this test done. and they leave. They'll not be diagnosed in time. They leave and they're still looking for the money. And life happens. They've got other priorities and so on. So they were told, go and do this test. By the time they come back now, it becomes more obvious. So some of those things, there are a lot of shortcomings in our healthcare system, and it's something that goes both ways. But one thing I want to encourage the public is, as much as possible, access the care. I know there's always a fear that, you will find this, you will find this. But the truth is, the difference is, if it's there, it's there. Whether you know about it or not, it is there, right? So, but at the end of the day, in terms of handling this, I understand the concerns that the public have, and they've got a lot of pressures, a lot of competing interests and so on. So when you tell people just go for screening, and especially if it's going to be costing them money, they've got other priorities, isn't it? They've not been able to put a million on the table. They've got school fees to take care of. They've got transportation. So there are a lot of competing interests. And that's why it's important from a perspective as a country, we have to prioritize these things, because we know the burden that cancer is causing in this country. Yeah. And we know the kind of resources we're deploying. We have to make sure that we shift this to preventive and promotive so that we minimize the amount of resources that are required at a later stage. And more importantly, improve the health outcomes so that we have got a productive population that can be able to move us to the level of Singapore 3.2.
I want to go back to that training thing that I mentioned. When doctors are trained, are they trained to understand and to have a back and forth with their patients? Because the experience of many people who've gone to doctors is the doctor tells you, he's the one who tells you and talks to you. And they don't accommodate questioning and pushback. Like, why am I being given this drug? I'm simply saying that are doctors trained to take the time, even as they're diagnosing? The pressure doctors are under, immense, there's no question about it. But if a patient feels they can talk with the doctor, the doctor is more likely to get more information. That's really what I'm getting at. Because they are asked, they answer, there's a discussion about it. But the pressure that is there's probably the feeling that, you really can't have that discussion because there are 10 other patients waiting or 20 other patients waiting. Now, you heard my question. Does training allow for that? Because you say it's both ways, and I agree. If I feel I'm talking to somebody who's going to be giving me instruction that doesn't want to listen to me, then I will give as little information as possible.
Yeah. The truth is, doctors are trained. Every doctor is trained in that manner. You have got to listen to your patients. You have to examine your patients. Then after that, you're going to make a tentative diagnosis. You'll do whatever tests that you need to do and come up with a diagnosis and provide treatment. No, it is part of the training continuously. That's all clinical training. However, one of the things that I have to accept, and one of the things I keep telling a lot of people sometimes, the reason why, for example, herbalists and quacks take away a lot of our patients is because of that aspect you're talking about.
Yes.
These guys have got nothing else. As we are thinking about all these pathological processes and processing stuff, these guys, they just sit and listen.
They listen.
And they give them time. And people feel that they've got hearing and so on. So they are more likely to feel, whatever treatment comes
they're
out.
Going to pick, they're going to pick the diagnosis from what you say.
And manipulate you. And manipulate
The neighbor.
Yes.
Huyo neighbor umetaja sana, there must be an issue with that.
Kuna macho.
Kuna mtu amepitia kwako.
Yes.
Akakuangalia vibaya. Kuna mtu amekusalimia juzi.
Kuna paka nyeusi hapo karibu na jirani.
Yes. But that's why it is important also for us to be able to optimize the use of our resources, including healthcare professionals.
Yeah.
Make sure that people have got a workload that is relevant, so that you've got, for example, and especially when it comes to specialists, let it be that specialists are seeing the patients they need to see, as opposed to seeing all the general. That's why streamlining the healthcare system is important. So you don't have somebody waking up with a headache in the morning and saying, I want to go and see a neurosurgeon, and occupying the space that somebody else who's been referred by another healthcare professional should take. So these are the things that we have, but of course it still boils down to the aspect of healthcare finances.
There's a term I came across.
You have 30 seconds.
No, that term can wait.
The city can we share that time?
Cut the story short.
I'll just go tell the story.
I think my opinion would be, and for us to understand some of these terminologies, like we're shouting about, bills and stuff like that being translated, how do you tell someone these are cancer cells that are in their mother tongue?
Anki Doris.
Okay.
I said city had 30 seconds. Now you're taking 40.
I am done. Just
Dr. Timothy Oluenyi, thank you very much for joining us today.
Thanks. Thanks for inviting me.
Dr. is the chairman of the National Cancer Institute, and he's been here talking to us about hospice and palliative care, because tomorrow is World Hospices and Palliative Care Day. As we commemorate that, we have now gotten to understand a bit more.
This is The Situation Room The only way to start your day.